Say, this is my family, wife. We've been married for almost 14 years, Nicole. We adopted 2 kids because we were not able to have any kids biologically, and then God gave us a third biologically, so that's Grayson. And you see him right there on my lap. This is my work family, which you guys know if you're a practicing dentist for a long time, you spend more time with these people than your family at home. I practice with, I'm in the center on the couch, the bald guy. The other bald guy above me is my dad, so I'm a second-generation periodontist. And I was actually born in Chicago when he was doing his perio residency here. To the sides of me are Dr. Summers, who's sitting in the back row here, and Dr. Marshall, my other partner. She's back in Colorado keeping the shop going. My team surrounding us, and as you guys know, you're only as good or bad as your team members, and we're blessed to have a fantastic team. Other than being born in Chicago, I'm a Colorado native and a big Bronco fan, which comes with that. So right now we're on hard times, but you can see in the middle, I was lucky enough to go to Super Bowl 50 and be there when we won. This down here on the lower right, my son and I got to go in the field before a game. One of my patients got us down there, and he got to meet his favorite player, Philip Lindsay. And just by dumb luck, when I was in college, I was dating a Bronco cheerleader, and she invited me to go to John Elway's retirement party, which was a pretty fun experience. So because the Broncos are really what I know, I'm going to talk about periodontics through the lens of football. And if anyone knows football or NFL, we have kind of 3 phases of every team. You have the offense, which is trying to score. You have the defense, which is trying to stop the other team from scoring. And then special teams, and special teams is the kicking game, field goals, punts, what have you. Normally, most players will play on offense or defense or special teams. Sometimes a player may play in 2 phases. But it's very rare where you find a player who can play in all 3 phases of the game. And it's probably been since Deion Sanders back in the early 90s when really a star could do that. My task here today is I'm going to try to tell you how BioExclude is the Deion Sanders of my practice. So, as a private practice periodontist, my practice is kind of broken up into 3 phases, just like the NFL. It's a little bit of a stretch, but try to stay with me. A third of my practice is treating periodontal disease. A third of my practice is dental implantology. And a third of my practice is soft tissue grafts. So there's our 3 phases. And I've been tasked with trying to figure out where, other than the traditional uses that we've seen, where could this go, and where can BioExclude be used outside of just extractions and GBRs? So I know that this has been hit if you've been here before in the previous 3 lectures, so I'm going to be pretty brief with this explanation, but what BioExclude is dehydrated human amnion chorion. So it's the placental or amniotic sac. It comes out from planned C-sections in live births, and then it's processed by the Perion process, and what they do is they peel apart those 2 layers of the amnion and the chorion, remove that intermediate spongy layer, put them back together, remove the epithelial layer. And so that gives us spongy layer out, epithelium off, laminated back together, and we have BioExclude. That processing is important because it allows you to position the membrane however you want. It doesn't matter the orientation. It doesn't need to be up or down. It can be sideways if you want. So why choose BioExclude? And for our use, it's because the 4 main attributes is that it's immunoprivileged. It lives between the mom and the baby, and it has kind of a privileged presence there. And that translates to other uses. It's anti-inflammatory. We already talked about the different chemokines and cytokines that are there. It's antibacterial, and I think that's a really neat thing that a lot of other products don't have. Most membranes and barriers are kind of bacterial wicking. This one is killing bacteria. and it also has accelerated wound healing. Can I see a show of hands who's used BioExclude before? Okay, so almost everyone here knows, so I don't have to tell you about how to handle it. So the great thing about it is like when you first start using it, it's hard because Dr. Cullum talked about how it's kind of like saran wrap and it starts sticking to itself, which is tough to get used to at first, but once you get used to it and you know how to handle it, it's easy and you use those to your benefit. It's safe to use to touch tooth surfaces. In fact, we do that on purpose a lot. It's thin and adaptable. You can leave it exposed. It has growth factors. We've seen all that stuff already in the previous hours. So why do we think that we can use this in the mouth? And as Dr. Holtzclaw talked about, is that this has been around for well over 100 years in medicine. It's used for ophthalmic surgery. It's used for for spine surgery, for nerve problems. It's used for sports medicine. It's used in the last decade or so for dental. And I think the most important one of these to focus on really is the chronic wounds in this middle, is that you have a non-healing diabetic foot ulcer. And if we can think about the wound mechanics of that, is that the problem is in normal wound healing, you have inflammation, then a proliferation phase, then a remodeling phase, and the wound corrects itself. But if you're, for whatever reason that is blocked, you start off with your inflammation and it just stays there. And they've shown in medicine that by using amnion chorion, you can maybe get over that hurdle and start healing. So if we can use it in medicine to do that, why can't we use that in the mouth to do that? And specifically, I'm going to talk about using that to treat periodontal disease, which is also a chronic non-healing wound. This is just a list, again, of some of the growth factors that are there, that are helping us to achieve these goals. So I'm going to start with talking about defense, which is implant surgery, because this was how I was first introduced to BioExclude, probably about 6 or 7 years ago, watching the Dans talk. That's Dr. Holtzclaw and Cullum that led before me here. And at that time, I was at a meeting in Beaver Creek, Colorado, and they were talking about using these membranes specifically for socket grafts. And at that time, I was still struggling with how do I do socket grafts to be predictable? Do you try to advance the flap and close it? Do you leave it open? What membranes do you use? Do you use a collagen membrane? Do you use a PTFE? And they showed cases like this where you get great healing predictably over and over again. So I listened to them and I bought a couple membranes and I started using it for socket grafts initially. I still use it for socket grafts now, but that was really at the beginning. All I did was that, and I would mix in occasionally with GTR, which Dr. Holtzclaw showed a lot of good cases with that. If you weren't here previously, also some of the key things you need to remember is you don't handle this. The rules are different with this than a traditional membrane, a collagen membrane. With collagen membranes, you need to trim it to fit the defect. You need to make big flaps. There's a lot of things you need to do. With this, you generally don't trim it. You just take whatever is closest size out of the box, stick it in there, suture. It's important to tell your patient not to rinse, not only not to rinse with chlorhexidine, but not to rinse with anything, because it's pretty fragile initially and they can wash it right out if they're swishing. So that's an important key to this working. This is not me, but this is how I suture too. It's just a figure eight, or I call it like a railroad track, because there's an X and parallels, just kind of locking it in place. So this is pretty much what I was doing for 3-4 years. And then I eventually, and I don't even remember how, met with Mark Lucas and Robert Toffe, who's the president of the company. And just because they are from Denver and I'm from Denver, they came to me and said, hey, do you want to work with us and try to figure out what else this can do? We have some ideas, but do you mind doing that? So I said, yeah, no problem. Let's play with this stuff. So I started trying to get a little bit beyond what I had done before. And these are starting with going, and this isn't amazing or fantastic, but this is just thinking more than just a socket graft. So this is a 25-year-old kid, is a ski patrol. When he was a ski racer as a kid, broke number 8. Then later in life, endodontic failure, and he's got, I'm going to see if you can see on the CBCT over on the left, not only a periapical radiolucency, but also a defect on the kind of mesial buccal of the root there. And I am a lot more conservative than Dr. Cullum. I do a lot more delayed implants. So in this one, I decided that I was going to remove the tooth, socket graft, and come back later. And because of the bony defects, I felt like I needed to do something to make sure we get it cleaned out and graft it and contain the graft. So I used kind of a variation of the ice cream cone technique, which I think Tarnow talks about. So I took a long, skinny bioexclude, tucked it all the way down to the apex to capture that entire defect, then put the bone in, and then tuck the membrane over the top. And this, you can see the suturing technique here. And while I was doing that, I had one of my assistants cut off the root of the tooth, filled in with composite, polished it off, and then we gave him that in a suck-down S6 for his initial temporary. Then healed 3 months, and most of these, what I do is I scan at 3 months and plan to go back in at 4 for the implant. So at the 3-month scan, it looks like the bone's healed in and well so far at the apex, on the buccal, it looks like it's regenerating. He also had really good soft tissue thickness still, so I decided to go back in and do a flapless guided implant. So guide goes in, implant goes in, and then he went straight over, so we got really good fixation, so then he went right to his prosthodontist that day to start doing the immediate load provisional and developed it. So that works. So then I tried to, next level is step it up to get a little bit more complex and see if we can regenerate bone down deep, can we regenerate bone at the crest with aesthetic issues? So this patient came in and she has a previously placed implant in number 8, and she's maybe 25 years old and about to get married, which is perfect scenario, right? And this on the far left is her initial, and it had been attempted at previous perio offices to do soft tissue grafting, but because of the infection, you can see also the implant is, I think, is a little bit too shallow. And as you can see in this top right photo, it's also placed too far facial. And so there's no amount of grafting that's going to get over those hurdles for us. So we decided we had to remove the implant and start over. One thing I've found helpful in these explantation cases to get good regeneration is to first remove the crown and the abutment and all superstructure, put on a cover screw and let it heal like that for 4 to 6 weeks. And then you get some soft tissue falling into the space and it almost gets resubmerged, which allows you to get primary closure a lot easier. Then I used a torque out tool, whatever, there's a million of those now, to spin the implant out. And you can see this is just, it's spun out really nicely, and then you can see over here our residual defect. Ooh, this thing's not working. Right here. You can see up here, that's how the facial access that we had on it. So a residual defect on the facial. So we need to regenerate that as much as we can because we need to get a good aesthetic outcome. We need plenty of bone, plenty of soft tissue on the facial. So over here on the left is the steps I went through after I just grafted it with allograft bone. This is the dry bioexclude membrane placed dry, and then like the videos you've seen before, once you get it wet, it adheres just to it sucks down right on, just like if you've got saran wrap and put it on your thumb, it sucks down right on it. As long as it's not soaking wet and there's too much blood, it'll float up, but it's pretty consistent like this, then you can close it up over the top. Then, as we do, 3 months later, took a scan, and it looks like we have good bone healing. There's not as much thickness buccally as I would like because I didn't overgraft it enough. So then order a CBCT surgical guide and went back in. Now this is 5 months after, and you see over here, like the re-entry, the bone is really, really good in that area. It's completely regenerating. You cannot tell the difference between the native bone and the grafted bone. Then pilot drill confirming that we're now on the correct trajectory and not out to the facial. then place the implant and graft it on the buccal, which I just wanted, this is more like a contour graft. The implant is 100% in bone, it's just thin, so I wanted to bulk it out. And for that, instead of using, I use actually BioOS and BioGuide just to bulk it out more, because that's something I think is going to stay there. Put on a shorter healing abutment, advance the flap and close it over that to develop more tissue, and then uncovered, pushed it facial, and the prosthodontist started with his tissue development, and that's going on right now. In implants is also used for GBR, and we've seen a lot of that so far. I just wanted to point out, and again, this is not one of my cases because until recently I haven't been photographing most of my cases because I'm just cranking through doing perio. But some important differences here that I want you to see is that I was trained, and I've always done my GBR with kind of the sausage technique that Dr. Urban teaches, where you have to make your incisions at least 2 teeth distal to your defect with your verticals, and then you're using BioGuide and tacks. Here it's different. You're not using tacked-in membranes to retain your graft, so you have to use your flap design to retain your graft so it doesn't get away. And Dr. Lucas taught me that. So if you see here that the verticals are placed almost right on the edge of the defect, then the particulate goes in, the membrane over the top, no sutures, no tacks, anything. It just sucks right down on it, and then advance the flap and close it over the top. And this is a fantastic result. You go back 8 months later and you have tons of bone there. So again, different mentality is that we're used to making these big flaps, big releases, tacking everything in place. With this, you don't need to do that, and you probably shouldn't do it, because if you make these big wide incisions, the bone's going to spread and fill that void if it's not locked in. Then the last couple applications I want to show here for defense in implantology is sinuses. This case on the left was a patient who general dentist in town decided they would take out the tooth and socket graft it and do an implant. But they did a socket graft and it didn't work too well, and at least they knew that the weekend course on crestal sinus bumps wasn't enough for this case. So they referred this patient over to me, took a CBCT, and we see, you can't see the numbers, but it's just under 3 millimeters of vertical here. And you want me to click? Good, thank you. Just under 3 millimeters of vertical. For me, this is a 2-stage, but I don't like doing a lateral window in between 2 teeth. And I thought this would be a good opportunity to do a 2-stage crestal bump using the Versa technique and NovaBone. So this is immediate post-op on the right. We went through just the Versa protocol, drilled the hole, pushed the NovaBone up through, and then I fill the socket all the way up with allograft, and now it's almost like an extraction socket, and you need something a barrier over that, so the BioExclude goes over the new osteotomy and closed primarily. Incidentally, if you're doing this and the membrane tore, you could also use BioExclude to perforate it, or to cover it up, and we're going to see that here. 4 months after that lift, the bone is still there and it's turning over. So then we go in, and again using the Versa densification burrs, place the implant. So we went with a crestal approach from just under 3 to easily putting in a 9 millimeter fat implant. And from there to there. So I have some slides here of sinus perforations, but none of them are mine. Not because I've never perforated a sinus, but because when I do, my first thought isn't go grab the camera, let's document this. It's kind of like, all right, let's fix this. And it's always been a challenge to fix it. And until recently, this is by far, I think, the easiest utility that BioExclude offers, because it's probably the closest biologically to the Schneiderian membrane. If you think about them, they're both membranes that are separating spaces, whether it's separating mom from baby or it's separating nose and sinus from mouth. It's the same thing. So if you get a little perforation here, you stick the little smiley BioExclude on it, dry, and as soon as it gets wet, it's like Scotch tape. It just sucks down and immediately immediately seals it off. So this is a bigger perforation. And the keys here is, as big as the perforation is through the membrane, you just have to be able to capture the borders and find a membrane in your arsenal that's bigger than that hole. Then you can capture it and then just move forward with your grafting technique. It adheres just like a patch. So I want to show over here a video of what that looks like. And we've seen something similar from Dr. Holtzclaw, that you just stick it in and now you can just keep going right forward with what you were doing before. Okay, so now done with the implants, we'll move on to our special teams. To be fair, this isn't a utility that I've used this product for a ton, but some of my colleagues in Denver have and swear by it. They say it's been great, but they've never taken any photos of it to show it. So when I agreed to do this talk last year, they asked me to take some photos and try it with this use and see how it does. So here we go. This is my first case using BioExclude with soft tissue procedures. It was a recession, upper right. This patient had full mouth recession, really needed orthodontics, but turned it down. And our treatment plan here was to do really a coronally advanced flap of the entire quadrant, but then also augment 4 and 5 with acellular dermal tissue. What I would normally do in my practice and had traditionally is I would use Emdogain for this. So release flap, treat the root, go Emdogain, then graft, then coronally advanced flap. But in this, we used BioExclude instead of Emdogain because it's not just a barrier, it's also a carrier for biologics here. So I'm thinking that the rationale here is that this placing BioExclude as a kind of an interpositional graft is going to help the coronal position flap stick and also will help with the healing wound mechanics. So this picture up here, this is the BioExclude. So once the roots have been cleaned and flattened and then etched with EDTA, that goes in, I place it right at the CEJ, and you don't have to suture it in, you can't suture it in, it just kind of sucks right up there and sticks. Then I laid I think this is perioderm over the top of that, and with sling sutures secured that, then advanced the flap and closed it. And then at 3 weeks, suture removal, the flap is staying there and it's still a little bit bumpy. And then at 3 months later, it's holding and it's doing well. So we are able to get some root coverage there and thicken up the tissue on 4 and 5 area. And when I did this, I asked the patient, how was that? And he says, there's almost zero pain, which is not the reason I have been using it, but I've found that. And I'm going to show that there's more cases too, that seems to be the subjective feedback that I get back from patients, is there's less pain with that, especially if people have had grafts the other way before. Okay, here's another possible application, and I think this is the first documented photo they have of this use, is using it to help the wound mechanics of a palatal donor site. So I still use some palatal tissue, whether it's for a free gingival graft or for a connective tissue graft, in which case I use the de-epithelialized technique, so I still have a wound like this on the palate. And to try to help the healing of this and reduce the patient's pain experience a little bit, after I harvest the tissue, I take it out and my assistant puts pressure on it with gauze while I'm preparing the graft a little bit, smoothing it out. Then I go, and this is almost the same suture technique that I would use for the extraction socket. It's that same kind of figure 8 suture. And then we just leave it like that while I go and suture the graft in. Then I come back 10, 15 minutes later, and there's a nice clot there. And I take a piece of BioExclude and I just kind of slide it underneath the sutures so it's held there. And it's not it's not held there very strong by the sutures. So what I do is over that then use, and I don't know if you guys still have this in your cabinets or not, but I use Copac or Periopac, which is a technique I was taught by my dad when I started, to cover that up to hold everything in place. And then patient comes back, this is like a 1 week post-op, and it's healing a lot faster than I would normally see these heal. So pack comes off, sutures come out, Patient said 0 pain from the palatal to donor site, and I've continued to do that. It's a little bit challenging to handle it and get that fished underneath the sutures, but if you can get it and hold it in there, it works fantastic. Then, so again here, initial recession, 1 week. This is a 1 month. It's not the best result on the graft, but it's healthy. But 1 month on the bottom right here, you can't even see where the donor site was anymore, and that was a pretty decent sized graft. And then, I wish he was here, but he's not, this is a spin on, if anyone here is doing Wilcodonics, this is Colin Richmond's version of it, which is pre-orthodontic periodontal augmentation. And 1 year ago at the corporate forum, I was sitting with him, and I said, this might be a good indication for BioExclude as well. So I photographed a case of doing it. This first photo on the bottom left is patients referred to me by an orthodontist. They have recession, planned for orthodontics, and we know that if we're going to push these 12 and 13 facial, that recession is only going to get worse. And this is a really sharp orthodontist that knows that, so sends a patient to me saying, let's graft this. And at the same time, why don't you give me some corticotomies and maybe we can speed the tooth movement up. So the steps of the surgery, first of all, he puts the brackets on because anyone who's Wilco, we need to activate the orthodontics within really 5 days to capture the speed. So brackets go on. Then surgery, she comes in, elevate the flap, do periodontal things, clean the roots. We notice a little dehiscence on the facial of 12 there, and we'd already known that from the CBCT. Then using a piezo surgery, make corticotomies just on the buccal between the roots. And I also harvested a little bit of bone chips with the scraper using a piezo. Then EDTA on the exposed roots where I'm hoping to get new bone. Then the autogenous bone chips go first on that exposed root, and then a layer of allograft bone over the top of that. Then BioExclude over that. So you can see right here, it's great. It's like tape. You just put it on there and you get it wet, it sucks right up. Then advance the flap and close it up. And then this is wrong, is that I just realized when I was fact checking my stuff the other day, this is not even 3 months, it's only 10 weeks. So you can appreciate how much movement the orthodontist was able to achieve, possibly because of the corticotomies, but the recession hasn't gotten any worse. In fact, we've gained some root coverage as they've pushed the teeth buccally. So indication for BioExclude in my practice. The last thing I want to talk about is offense, and that's treating periodontal disease, which I think is getting cooler for periodontists these days, hopefully. So I want to talk about how we're using BioExclude for periodontal disease. And I'm going to start with kind of a crazy case. This is a patient that came in and she had this blown out class 3 furcation on tooth number 31. And as you know, there's no real predictable way to fix that. So we had that conversation. I said we can root amp it, we can do a hemisection, we can do titanium therapy, or we can try a Hail Mary and see if we can graft it. And she asked for that. So knowing that it wasn't going to probably work, and we told her if it doesn't, then we'll take out the tooth and replace it. We won't charge you for the extraction. So preoperative, we have a class 3 furcation all the way through both sides, 9 millimeter pocket depth with pus and blood. You can see the CBCT showing the through and through defect. And then I treated this with a combination of BioOs collagen in the furcation and BioExclude covering both sides, so trying to lock it in. And then at 9-month reeval, probing depth from both sides are 3, the tissue's healthy, and the CBCT shows something there. I mean, it's BioOs collagen. It's probably not true bone if we're going to take it out and cut it, but it's probably the best we can do at this point. And we'll see how long this is, a couple of years out now, and it's still doing well. And then I realized while I was putting this together recently that I didn't show everyone how to do that, and this is a surgery I did last week, and it's very similar, so I had my assistant grab the camera, and I said, let's go through the surgery and show these guys how we did this. So same thing, number 19, through and through defect, probably hopeless tooth. Pre-op x-ray over here, see the class 3 furcation, pre-op photo, So flap it, you can see why there's a defect here. You can see calculus. There's also a little enamel projection. So first thing is root and defect debridement, clean it out. That's with piezo scalers and hand instruments and all the things we know how to do. I also use a burr to kind of like unroof it, kind of like swoosh it in a little bit. Then, and all this is done, I don't know if you guys really enjoy taking lingual photos, but I don't, so I imagine everything's happening twice here. And then this tetracycline soaked pellets go into the defect to etch it and to help with the antibacterial properties. Then I get the BioOS collagen block, cut it into little pieces and hydrate it. And this photo here is showing right when that's packed in. I use the BioOS collagen partly because I know it's going to be there, but second because the handling properties, it's easy to pack in. And then as it continues to bleed, it hydrates and saturates. Then the BioExclude is placed. Now I usually place these wet. I feel like it's gotten easier for me to do that, so I lay it in here. And this is again buccal and lingual, and let it soak up and block everything off. And then advance the flap and close it, and put a little finger pressure on there to make sure that everything's staying where I want. And take an immediate post-op. Now this is, who knows what that's going to look like in 6 or 9 months. This is only a week old, but I've done a handful of these and they've been pretty predictable thus far. And then Thursday, right before I left, the guy came in and took a 1 week post-op photo. Now I probably should put one more suture in the vertical, but it's doing well. And again, this same thing, like that was amazing, zero pain. And I cut him open pretty good there, but it's zero pain. I think that's part of the membrane and the biologic to that. And then this is a GTR, and Dr. Holzclaw showed a lot of these, where we have a deep defect down the distal of 30, also recurrent caries on the crown, open contact. So we endo-tested it, make sure it's fine. And then I asked my general dentist colleague to put a temporary crown on it to close the space. And that's over here. They didn't do a really good job of closing the margin, but at least they closed the gap so there's not food impaction in there. And then I did the same kind of surgery, opened it, cleaned it out. This is allograft bone hydrated with Emdogain, BioExclude over the top. And then at his 6-month reeval, he comes in and I see this. And I'm like, what is going on here? And he said, oh, that's probably, the crown came off last week and I went back to the dentist and they just popped it back on for me. So this is just cement from the assistant putting the temporary crown back on. So I just shredded that out, asked him to come back a couple weeks later because the tissue was really not happy. And this is 3 weeks after I cleaned it off, and now at that point you've gone from 11 millimeter pocket depth to 3 and 4. And then he got a final crown, and I'm waiting to see the x-ray of that. Okay. We're going to talk about minimally invasive laser flaps here. And to give you a little bit of background on that, in addition to doing normal periodontal surgery, I've also, in 2012, was trained on LANAP. And I've also been through training from numerous people, and I've learned a lot about the mist technique and the modified mist and a lot of different ways to skin a cat, so to speak, to treat periodontal disease. And over the years, I've been now 7 years of doing LANAP, I've wanted to get better and better because I'm not always getting fantastic results. So I'm trying to think, what can I do to tweak this? And I always be getting better. And I took a hands-on course about the minimally invasive surgical technique where you make a little tiny flap, poke in, clean it out, Emdogain in the defect, close it. And I thought that's pretty similar to what I'm doing with the laser, is we're kind of making a little incision with the laser, removing the pocket lining. You can see in there pretty well with you blow in some air and you can clean it out. But then I was just letting the blood clot fill it, and I thought, what if I add Emdogain to it? Is that going to help? Or add a biologic to get a little kick? So this is one of the first times I tried that on this great lady. She had this giant defect on 11 because what happened is she had some early periodontal disease, and then went through ortho, and that generally doesn't help periodontal disease. So she ends up coming to me with these giant defects. She had this on all 4 canines and her first molars. And we treated this. I did using Periolase, but instead of using their normal protocol, so this is not LANAP anymore because I'm off lay 1 off protocol, as I would clean it out, put Emdogain in the defect, compress it with a wet gauze, and then let it heal. And then 9 months, you have good bone fill. And 3 years, it looks like it's holding up and probably getting a little bit better. The tooth also migrated a little bit back into the correct orientation, because we also did some bite adjustment and got her in a night guard as well. So if it works like this on one, I did this off and on for a little bit. Then I started doing it with full mouth cases. So whenever we had a bone sounding defect deeper than 6 millimeters, I would add Emdogain to it and usually get really good results. And I started, but the thing I didn't like about it is I wasn't sure that was getting where I needed it to be when I inject, so I wanted to see if I can do something else, so I started using BioExclude. Same utility. This is the first patient I did that with, and I didn't want to go full bore, and I had the full conversation, so he is, consented, knew what he was doing. I discounted his surgery because he knew he was going to be a guinea pig, not really, but he knew. So I did half the mouth with Emdogain, half the mouth with BioExclude, using the same way. So I'd clean it out, and then tuck the BioExclude into the pockets, and then follow from there kind of the traditional LANAP protocol and reeval at 9 months. This is our initial. We had the full mouth is 5 millimeter pocket depths, really. And then up to the pockets that are 7 and more averaged 8. And the top is pre-op, and the bottom is a 9-month reeval using this technique I call the MILF technique. And you can see over here, you're getting, even though these teeth, this number 31 and number 15, this patient knew from the beginning, these are huge defects, not good prognosis for them, but he wanted to say, let's just wrap it in and see what we can do, and then reevaluate and see what happens later. You can see there's really good bone fill on both of those at the 9 month. I mean, you don't see that very often, so I think that's really promising. And then ran a little bit of data on this with the help of Snoasis. This is again an N of 1, but we can see that overall we went in this case from an average probing depth of 5 to just under 3. When you take just the pockets that were 4 and more, we went from almost 6 to just over 3, which is an improvement of 2.5. And when you go the deeper pockets that are 6 plus, you went from 7, almost 7.5 to just over 3.5. So almost getting an improvement of 4 millimeters per pocket. Then one more thing I want to point out is that for those interested, that the comparison between the BioExclude side and the Emdogain side, the Emdogain seemed to be a little bit better, but now my interest is peaked, so now I'm going to do more of these and really get some better numbers, like maybe 20 more patients doing the same thing and see how it pans out. This is just a series of photos showing the technique. So the preoperative probing depths over here, it's 7 millimeters and pussing. It's the distal side of this bridge abutment. This is a 75-year-old lady. This is first pass with the Nd:YAG laser, and kind of removes the epithelial lining, cleans it out a little bit, also is killing some bacteria, and hopefully. Then if you blow air in there, as I said, the flap kind of pulls away, and you can see really well to clean it out. So then root debridement using piezo scalers and hand instruments. Then the BioExclude is trimmed, and I place it dry first with like a cotton pickup, and then use a file to tuck it down into the defect. Okay, so now our thought process is this is a chronic wound. I want something to help it heal, so we're going to clean it out, give it a boost, and then see what happens. Tuck it in, then damp gauze to compress it against the tooth, and then over here, I think this is a 1-week post-op, and I am not good enough with microblades and microsutures to maintain a little tiny isthmus of tissue that well at 1 week. But I think using a flapless laser approach allows you to maintain that, and it allows you to, over here at 1 month, you've maintained all the tissue from pre-op, and hopefully what's underneath is doing its thing. And I'm sorry that I don't have follow-ups on one of these because I'm not in the habit of taking photos, so I have x-rays and charting of a lot of history of these, but no follow-ups on the photo cases. So if it works with teeth, does it work with implants? And this is one of the first implant cases I did using this kind of technique. On the far left is initial presentation as a patient. She comes a bunch of implants placed, I think in Chicago, by a prosthodontist. She's a heavy smoker and they're all pussing, losing bone everywhere. So we had a discussion of treatment options, decided to treat them using a combination of the laser periotherapy and biologics. Specifically in this one was, I think, Amdigain. Again, an older software didn't even allow me to put a visual of an implant in there, but before 9, 10, 12 was the pocket depths. At her 1 year post-op, those are down to 4 and 3s that are non-bleeding. You can see this middle x-ray. This is 4 years later, and the bone is completely regenerated to the top thread, and the pocket depths have stayed at non-bleeding 3s and 4s. So this is showing that you can have stability even around an implant. This is no graft over 4 years using the laser and biologics. Then the last thing I want to talk about is using these potentially for a non-surgical application. So not with laser, not with GTR, not with GBR. Just your patient comes in and they have a periodontal abscess. You might use a Restin or a perio chip or something like that. You can maybe consider using this there. So 7 millimeter pocket down the facial of 31, pussing, swollen, pain, get it numb, debride it, tuck your bioexclude in there. It's, again, it is antibacterial, which is like your Arestin and those other products. I'm using so many brand names, I'm never gonna be asked back. But you're also having growth factors there. So same protocol, get it numb, clean it out, tuck it in, and then 6-week reeval like I would do with a scaling root plating or other non-surgical things, and it's now 3 millimeters and no pus, no bleeding. And I've started doing that more and more. Now, this is, I think, a powerful slide that shows this is a research project that was done at the University of Colorado Perio program, where they just took a petri dish, inoculated it with AA, cut a little circle of bioexclude and threw it on the tray, and you can see that's really cool how it kills not only the bacteria there, but a zone of inhibition. So that's what it's doing in the pocket, which is fantastic for us. There's also a small trial going on using it for a non-surgical application where they found really early promising results of pocket depth improvement and bleeding improvement on par with, or if not better than, Arestin and other competitors on the market. And there you go. So, bioexclude is Deion Sanders. That's the end. Anyone have any questions? Yes.
A couple questions. So you're using this as a biologic instead of the last step of the laser protocol, the hemostasis?
Yes.
Okay. And then the second question is, since this product can be on the expensive side, are you coding it as a biologic, per site, or is that the plan moving forward if you find this to be effective?
So normally what I would do is, yes, I code it as a biologic, but I don't do per site. I just have one kind of quadrant fee for however many I do. Yes?
You repair your membranes.
Yeah.
For a tear on the sinus wall.
Yes.
How do you prevent that from hacking the bones or sliding or bridging or rough?
Because it sticks.
So it won't move it.
No, it doesn't. It really literally adheres. It just sticks to it. And as you pack those first couple, you'll see as you start scooping bone in there, as long as you can see it's not moving, and the membrane goes right up, and you take a postoperative CT, and it's always contained.
Secondly, for those of us who add an antibiotic to our grafts,
Yes.
is there any downside to doing that with biology?
I don't think so, and in fact, I meant to talk about that as my protocol for this is growing and continuing to change, I've started doing some oral DNA testing before for periodontal disease specifically and putting the patients on a customized antibiotic protocol based on that. So I don't see it. Do you know of any contraindications to that, Ashley? No.
But I'm on
You're saying in the bone?
In the bone itself?
I don't know. I don't think so. You mix like tetracycline with your bone?
Veterinized.
Yeah, I'm not aware of that. So my partner in the back has not used this before. She's used it once, and that was because it was on me. She had to take out my tooth, and I made her use it. Hopefully she'll change her mind now. Anything else? Yeah.
So for the putting the bio screw into the vertical defects without putting bone in there, that membrane the picture showed the membrane is big.
Yeah.
So you should just like shove in there as a membrane, wind it up as a membrane.
It's not like a membrane at that point. At that point, you're using it more like a biologic. It's not a membrane at all. So you're just literally pushing it into the hole, push it into the defect, and it'll crumble up, and as it breaks down, it's over time delivering biologics to the area. Okay? Thanks, guys.